Somebody asked Dr. Mahandi if our colleague from Tunis, he asked about monoclonal antibodies in the treatment of optic neuropathy. Do you have any comment on that?
Yeah, of course. I mean, we can have any kind of treatment. I'm not saying that, of course, we usually start with steroids in most of the patients if they don't respond to steroids. So you can have any other kind of treatment. You can have any kind of biological agent. And we can have, they have tried rituximab, then tocilizumab, there is teprotumumab. So there is any kind of biological agent, not necessarily monoclonal antibodies, even newer agents. But here is that sometimes people insist with medical treatment, and I agree that we should not put our hands on any kind of patients, but there are some cases that would need a decompression anyway. So I think when we identify these patients, we should not waste our time and money, basically.
Very good. Very good. That was our colleague from Tunis, Mahdi Fandari. Now, there is another question from Dr. Nasser Karmi, who says, would you recommend doing strabismus surgery at the same time of orbital decompression?
I have just reviewed a series of patients during the lockdown. I've written a paper. I hope it will be out as soon as possible, reviewing a series of patients in which we did orbital decompression and vertical strabismus at the same time. There are some very good papers that say that even horizontal squint could be done together with decompression. But in my opinion, horizontal deviations change after, they might even improve sometimes. But what I find is after decompression, you can have an improvement or of esotropia or an esotropia getting worse, but even if it does get worse, you can have a deficit of abduction. So basically, I always reserve horizontal strabismus at the second stage, but I always do now, if there is an inferior resector, inferior rectus to be recessed, I do it at the same time of the decompression. So we start with the endoscopic decompression, then we do the inferior rectus recession, then we go ahead with the lateral wall decompression, and we finish with upper lid retraction surgery if need be.
Okay, fine. Well, I will be commenting on this at the last talk. And now, Dr. Hisham Idris, he's with us. If you can give him the mic, he has a question, and he say, or should I, can you rely on imaging, apical crowding, or EOM size to make your decision on orbital decompression?
Can I rely on
just on imaging, like apical crowding or the extraocular muscle size?
Okay, I mean, basically that's what we have. So we have imaging to see that. I think imaging tells you the truth about crowding. Of course, we have to have clinical signs as well. So what I tried to say in the beginning of my talk is sometimes it's very difficult to detect optic neuropathy. You don't have patients that are blind or that just see they have very poor vision. But if you have just the Ishihara plates are not that fast, and then if you just have a very subtle RAPD, and then you have apical crowding, then I rely on CT scan, and then I would do a decompression.
Okay. Thank you, Dr. Francisco.
Thank you.
I think we stop at that.